Welcome to drug distribution. This slideshow will precede drug metabolism, so that will be next. And after that, we'll actually start getting into all the different pharmacokinetic models and a lot more calculations. There will be a few calculations in this lecture, and if you look in your handout, the student version, there should be some blanks in there, and I'm going to expect you to write those in. So I'm going to be asking questions and pausing it and then providing the answers in this slideshow. So I want you to be prepared just to do a little bit of writing, not too much, and hopefully some of your own calculations on paper or on your phone to try to answer these questions. And yeah, some of this will be on the test, some of the volume of distribution calculations and that kind of thing. Out of all the lectures, this is probably one of the shortest lists of learning objectives that I have. And those are to describe the physiology of drug distribution. So yeah, we're going to bring back a good amount of anatomy and physiology, but then in the context of drugs. Explain how drug distribution is affected by blood flow, protein, and tissue binding. Very, very important clinically relevant things, particularly protein binding and blood flow. Describe how drug distribution can affect the apparent volume of distribution. It's really important for you to understand throughout this whole lecture that when I say volume of distribution, I'm referring to the calculated volume that is apparent. It's not a real volume, and you have to understand that all the way through, why that is not a real volume. And I'm going to try to illustrate that in a few different ways. Explain how volume of distribution, drug clearance, and half-life can be affected by protein binding, and that's particularly plasma protein binding. Determine drug protein binding constants using in vitro models. So a little bit of calculations there. Evaluate the impact of change in drug protein binding or displacement on free drug concentration. Again, some really practical stuff that you might be able to use in clinical practice in some cases. So this is the introduction to the physiologic factors of distribution. Once a drug is absorbed, the location and extent of distribution depend on the physical chemical properties of the drug and the physiology of the patient. So things like lipophilicity of the drug. So is it ionized or is it nonpolar? A drug size, and then of course physiology, as I said here. So organ function. Does someone have poor blood flow to an organ because of a disease like cirrhosis, for example? Does that affect drug distribution into that organ? So all those things are going to be important. Organs of distribution can be excretory organs or non-excretory organs. And I just want you to pause it after this question. It should take you just a few seconds. Can you name a few of each excretory organs and non-excretory organs? So go ahead and pause it right now. Okay, so the answer is, I hope you paused it. The answer is excretory organs. The main ones are the liver and the kidney. Those are really the primary ones. Nothing else is considered a real excretory organ after that. The non-excretory would be things like the brain, the lungs, the everything else. The adipose is a tissue, but that would count as a non-excretory tissue. The spleen, the pancreas, and all those things. Everything other than the kidney and the liver. Special organs can accumulate drug. We're going to go into one example. Why can sometimes breast milk, accumulate certain drugs even higher than the plasma concentration? Placenta, and I'm not going to get into that too much, that's a specialized area, but certain drugs can get into the placenta and certain ones do not, and that's why you have a lot of variability in the warnings on different drug labels. Salivary glands, yeah, I mean sometimes you can detect drug in saliva, so those are special areas where you'll get drugs sometimes. Protein binding is a major factor in drug distribution. And the key point, really critical point, is albumin does not easily cross through most capillaries. Okay, and that's most, not all, but most. So the assumption is that if a drug is on albumin, it does not easily go through capillaries, right, for the most part. So that in general, albumin binding will slow down drug distribution or reduce the volume of drug distribution. And there's more on that coming up. So real basic stuff to start this intro again. An average person has about 5 liters of blood and 3 liters of plasma. You could see on this pie chart that you have about 27 liters intracellular, and that is a lot of fluid if you think about it. And again, I always use the analogy to a gallon of water. A gallon is like 3.785 liters, so almost 4 liters. So that's a lot of fluid in the intracellular compartment. Interstitial, and then plasma. So plasma is your smallest amount of fluid in the body. So there's a lot of opportunity for distribution into other tissues. Again, intracellular is most abundant. So recall that several types of capillaries exist. Hopefully from physiology, recall that. And they have different degrees of porosity. Does anyone remember what are the most leaky capillaries? Does anyone remember that? And just think for a second, and you may not have to pause it, but just think for a second about that. And if you didn't come up with it yet, you may have trouble. So the leaky capillaries, the most leaky are really the sinusoids in the liver, because they have to be permeable to albumin, because albumin is made in the liver. Okay, the glomerulus is somewhat leaky, somewhat selective, but it's not as leaky as the sinusoids in the liver, because the glomerulus does not filter albumin. Other than that, most of the capillaries are all similar, except for the blood-brain barrier capillaries in the brain. Those are the most restrictive capillaries. So they have the tightest junctions, and they don't allow most things to cross. Most drug distribution requires diffusion out of or into capillaries. So that's the important point there in the reason why I'm talking about capillary porosity or permeability, is because drug distribution doesn't occur without capillaries, without some leakiness in the capillaries, because all the drugs start off in capillaries, whether it's going from the portal vein to the sinusoids in the liver, which are capillaries, or if you have an IV drug, then it's going through the rest of the body, and all those arterioles turn into capillaries at some point. So it has to distribute starting there. So a physiologic factor, as I mentioned, in drug distribution is protein binding. It's a major factor. So when a drug binds to a protein in the blood, it is no longer free. So from this point on, you should understand throughout all pharmacotherapy and rotations later, if someone says free drug, they mean not bound to plasma protein. If someone says protein-bound drug, they're usually bound to one of these proteins in this table. So these are the major ones listed in this table. Okay, albumin is, if you look at the concentration range in the plasma, albumin is a very large percent of plasma protein. If you just look at the concentration, so 3.5 to 5.5 grams per deciliter, that is a lot more than this other one called alpha-1 acid glycoprotein. Alpha-1 acid glycoprotein does bind to specific drugs, though, so that is relevant, but albumin is more abundant. And then weird stuff. Okay, so we have lipoproteins. Remember, we think of these as, we're just thinking of like, hypercholesterolemia and atherosclerosis, but these things can bind to drugs. And sometimes, I don't know if you remember this, but chylomicrons are made in the small intestine. So sometimes a drug will latch on to a chylomicron and follow that rather than going into the portal vein. And that's not common, but lipophilic drugs do that. Some of them, at least. So it's important to understand at least the first two are the most important. Okay, those are the primary plasma proteins the drugs will bind to, though. Again, it's the first two. The next thing that's absolutely critical to understand is that if the liver is damaged, yeah, we will see, if it's damaged enough, we will see a decline in these proteins because they're synthesized in the liver. So if your liver is damaged and these proteins drop in the plasma, then the next question is, what does that do to any drugs that bind to these proteins? And the answer is, if there's less protein available, then there's less drug bound. That means more drug is free, because even if it's about the same amount of total drug absorbed, some of that drug will not get to bind to the protein that normally would, and that drug will be free to do, to flow more easily through capillaries and usually get eliminated faster and distribute faster. It's really important to understand how plasma protein will drop in severe, usually liver failure and cirrhosis preceding liver failure. You can see that drop in albumin, and that's got a lot of other hemodynamic effects, but definitely effects on drugs as well. So the general rule is that if some drug molecules are stuck on albumin or any other plasma protein, only the free portion will be distributed across capillary walls and into tissues, and that's what I just mentioned. There's one major exception to this rule, and it's been proven that some drug transporters have a higher affinity for a drug than albumin does, and they could literally pull the drug off of albumin if it gets close enough. If the drug albumin kind of conjugate or that pair gets close enough to a transporter, they've shown that sometimes that can get pulled off, the drug can get pulled off the albumin and still get transported. So there are drugs that are 99% protein bound. That means 99% of the drug in the plasma is bound to protein. But some of them get eliminated quickly by the kidney because they're transported. And a lot of those are cephalosporin antibiotics like cephalexin and cephaloridine and all those in that class. So this table has diffusion across capillary walls, and this is to help you understand why when a drug is stuck on albumin, why it has very poor distribution, if a lot of drug, right? Some drugs are 50% bound, some of them are 99% bound. If something is 99% bound to albumin, referring to a drug molecule, it will move like albumin, right? This is called the diffusion coefficient. That's centimeters squared per second in 100 grams. I think it's 100 grams of tissue. It's kind of a strange unit, so I wouldn't worry about that, but it's just meaning the relative speed we can look at, the speed of movement through the capillary compared to water, less than 0.001. So albumin is extremely slow diffusion compared to water. And urea and glucose are very small molecules. You could think of those as, if a drug molecule were small like that, and there are drugs that are almost as small as glucose, and some of them are a little bit smaller, but it's rare. But imagine if a drug moved to that speed free, but then if it's bound, it moves at the speed of albumin through a capillary. It's going to have a major effect on distribution and elimination as well. So it's really important to understand that. In this slide, we'll use the glomerulus as an example of how protein binding affects drug distribution. Honestly, the glomerulus is more related to elimination, but this same principle can be applied to other tissues. Okay, so the whole idea is that basically if you have something, if you look up here, you'll see that's supposed to be albumin. In that kind of that triangle, there's supposed to be the drug molecule. And for this small animation, the example is that two of them are protein bound. One of the drugs is not protein bound. And remember, the glomerular capillaries have a pore size that's too small to filter albumin, unless the glomerulus were damaged through hypertension or something like that. But so the whole idea is that these albumin-bound drugs should not filter through. Okay, so I'm going to go ahead and do that animation, and we'll talk about the numbers in a second here. Right, so it can't get through, and so where does it go? Remember, this is a continuous capillary, so it ends up going to the, from the afferent arteriole through the capillaries to the efferent arteriole. So this arteriole, remember that it still goes in parallel with the nephron potentially for secretion or reabsorption, but ultimately, remember, it goes to the renal vein, it goes back to the body. So if a drug can't get filtered, if it doesn't get secreted after that, that's basically secretion is the last chance, and that drug will then get back into the body. So remember, though, because it is protein bound, it won't be filtered, but there's a chance that it can be secreted later on. So it doesn't mean that all hope is lost for elimination of that drug. It means we better hope that we have secretory transporters that can handle that later on in the proximal tubule. So then if we have a free drug, it gets filtered, right? So in general, drugs that are free have a higher elimination rate than drugs that are bound. And then just one more example, can't get through. So obviously the more drug binding or protein binding for that drug, the less elimination. If we remove some of this albumin, more of the drug would be free and more of it would get filtered. We'd have faster elimination. Okay, so if we want to get to the numbers, we can see here, just an example, hypothetical, if 90% of a drug is bound to albumin and 10% is free, that means only 10% is available to be filtered to enter the proximal tubule, through the glomerulus. Since this is something I don't expect you to memorize, but it is accurate that each glomerulus only allows about 20% of blood fluid to filter. So every time the plasma passes through, only about 20% of it is filtered each time. The rest of it continues through. So we end up with only, in this case, we end up with only 2% of total drug in blood actually being filtered upon each pass through a glomerulus. That means, because 90% is bound, only 10% is available. That's 0.1, but only 20% of that is filtered because it goes with the bulk fluid. So 20% of fluid goes through, 20%, so 20% of the drug goes through as long as it's not bound to albumin. All that means in the end is that only 2% of the drug available in this afferent arteriole will actually get filtered on this first pass through. So it's very limiting. Albumin binding is very limiting on drug filtration in the glomerulus. Okay, so hopefully that makes a lot of sense. And then, finally, he's free, literally and figuratively, because, well, he's free, not bound to albumin, and he's free because he's leaving the body, hopefully, because he got filtered, and he'll probably go into the urine at some point if he doesn't get reabsorbed. So this is a real-world example of protein binding and how it affects elimination of beta-lactam antibiotics. If any of you have worked in a pharmacy, you might have seen some of these. The classical example is cephalexin, but here we have ceftriaxone, cefazolin, and cephaloridine. And if we just look at the amount of protein binding, this 96% of ceftriaxone in the blood is stuck on albumin, or at least some plasma protein. And cephaloridine has low protein binding. If you look at the half-lives, ceftriaxone has the longest. And if we translate that to the renal clearance, because the half-life from the plasma, that encompasses all the different elimination routes, the two major ones, liver and kidney. Most beta-lactams are eliminated renally, though, so that half-life is mostly, caused or accounted for by the renal clearance. The renal clearance here is only 10, and we'll get into what clearance means specifically in a later lecture. But the lower the number, the slower the elimination. The renal clearance of cephaloridine is really, really high, so that's essentially the same as the creatinine clearance. So that is directly related to the protein binding, and that's a simple example that the more protein binding, the slower the elimination. However, if these happen to be transported, we might be able to overcome that protein binding, as I mentioned before. And again, this is elimination. Even though the kidney is, it's part of the first compartment, or the rapid distribution phase. It's mostly an excretory organ, but this same concept can be applied to distribution. So distribution into the brain or the adipose is going to be inhibited by more protein binding because of poor capillary permeability or permeation from that drug bound to albumin. So if a drug is bound to plasma protein, does that mean that the chances of elimination are gone? That drug is pretty much has no chance of getting out of the body? Of course, the answer is no, because protein binding is reversible. It's based on things like ionic bonds and hydrogen bonds and nonpolar interactions. It's not covalent, okay? And I'm not saying it's impossible, but I've never heard of a drug that covalently binds to albumin. So the whole point is that it's reversible. So like any reversible process, you can shift it. For example, if we removed free drug through elimination, that would create a driving force to pull more drug off of albumin, right? So it's that it's called like a sink effect. So if we drain, we'll drain the free drug, we'll pull more out of the albumin, off of the albumin. So for example, if 90% were bound and 10% were free, if all the free drug is eliminated, right, but 100% protein, or 100% protein binding is not the normal protein binding, right? If the normal protein binding for this drug is 90%, well, it's gonna try to strive for that or reach that 90%. So if we get rid of all the free, will gradually, and actually while the free drug is being removed, will pull more off of albumin to maintain this ratio. So it should never get up to 100%, right? It should constantly be falling off of albumin while it gets free. The free gets eliminated, more will come off of albumin, and it'll serve as a constant shunt until all the drug is gone. So it just means that it slows down distribution and elimination. It's not a permanent lock or prevention of eliminating that drug. And it looks like I already had the answer revealed here, but in your handout I think it's blank. So I apologize, the answer's already there. But so what would happen if a person had low albumin due to liver failure? So if you didn't get the chance to look at that, then please think about that and pause it and see if you can think of the answer on your own. But what would happen to a person if a person had low albumin due to liver failure? I think it's pretty easy, right? Low albumin, low protein binding, right? If you give the same dose of drug and of the same absorption, some more of it will be free, more of it than normal will be free, right? And then the drug will distribute faster and get eliminated faster, most likely. Okay. Something I didn't mention though is that usually, in every case, only the free drug can have a pharmacological action. So you might actually have toxicity when you have low protein, a low albumin concentration, because more free drug will be available to have a pharmacodynamic action. So that could be a problem as well. So here's a kind of practical example. This is a real one that I found in an article in a mouse model. They artificially increase plasma protein basically in a mouse model. And I think it was alpha-1 acid glycoprotein. Remember, that's the second one that I said was important. They can affect total drug in the blood and tissue distribution by increasing that alpha-1 acid glycoprotein. They use the drug imipramine. That's an older antidepressant that you don't need to know much about or anything really, but you should understand that it has to work in the brain, right? So more plasma protein caused a higher serum concentration and a lower brain concentration of the drug. So what I mean is not just free, but the total concentration. So if you force more plasma protein into the blood or into the plasma, some more drug will get stuck there. So then the serum, the total concentration of that's bound and unbound, or free and bound together, the total concentration will rise because less of it can distribute into the brain. So what you see in this is real data from a mouse model, is that in a normal mouse, the serum imipramine level was 320 nanograms per milliliter. The brain was 7308, or 7.3 grams, or sorry, 7.3 milligrams per milliliter. Alpha-1 acid glycoprotein, if we add more, artificially just add more, the serum concentration goes up and the brain concentration goes down. And that means because the protein is too big to get through the blood-brain barrier and the capillaries in the brain, that we're locking some more of that drug into the plasma, and we're actually impairing the efficacy. Now in a real patient, we very rarely see excess protein, albumin. The biggest concern in most regions of the world will probably be low albumin due to malnourishment, cirrhosis from alcoholism, or hepatitis, which also causes sometimes cirrhosis of the liver. So all those factors can affect and lower your albumin to cause, really wreak havoc on drugs that are protein bound. Because even if it's not a brain drug, you'll still affect elimination and distribution of other drugs, unfortunately. So hopefully you have a little bit of interest now in distribution, and I think it's just an interesting concept that we can actually affect the therapeutic response to a drug and the drug elimination just by changing something as simple as plasma protein. So what about the opposite? If we increase the drug concentration too high, I don't mean, so by opposite I don't mean, in this case I don't mean lowering the protein, but the ratio, going the opposite direction with the ratio. So if the drug concentration is much higher than normal, we saturate the binding sites on the plasma protein, what might happen? Okay, and for some drugs this is easier to do than other drugs. So if you look on this graph here, we'll see, and I don't know a lot about disopyramide, I don't think that's used very often. Lidocaine is an anesthetic, carbamazepine is an old, well, it's still used, but it's an anti-epileptic or seizure drug. And as we're going up and up in the concentration, this is this is this is a logarithmic scale on the bottom here. As we're going up and up in concentration, we basically will find that the unbound fraction or free fraction is the same, low, 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 low. So it's not changing, right? The same percent drug is free in this whole concentration range. But then all of a sudden we go a little higher, and all of a sudden the unbound fraction goes way up. That means the free drug fraction goes way up, right? So that means we've started to saturate our albumin. So, or whatever the protein binding site is, whatever plasma protein we're talking about, we're saturating it, and we have no more capacity to hold on to that drug. So now all the drug that you give, any more drug that you give, is going to be free. So that the unbound or free fraction is going way up. Remember, that's the pharmacologically active form, or the free form is what's going to be pharmacologically active. So that could be a real risk, right? All of a sudden, because lidocaine is also used for arrhythmias, all of a sudden we get to a certain point where, wow, all of a sudden the effect on the heart is much stronger as you increase the dose by the same amount. At this, if you're to this point, all of a sudden it's really having a dramatic effect, a dramatic change on pharmacodynamics and the therapeutic response. So that means it's a potential risk if you saturate protein binding, because then if you double the dose or whatever factor you change the dose by, it's going to have a much stronger response than if you did it in this range over here. And I don't actually know why. I think the scale from the reference I used here, I think the scale should be opposite, because the drug concentration is going up to the right. So these look like the opposite. So that it should be starting off the lowest number and then going up to the highest number as we increase concentration. So albumin is not the only factor, and plasma protein in general is not the only factor in drug distribution, right, and diffusion into a tissue. So you might remember from physiology that capillaries have a lot of forces acting on them. There's osmotic forces, and that's one of the main ones, and another primary one is the hydrostatic pressure there. So remember that there's a constant kind of interplay between the interstitial fluid and the capillary fluid, or the plasma. And in general, capillaries would have a net filtration pressure that is positive. That means generally more fluid will leave the capillary than enter the capillary. And that goes into the lymphatics, which is first the interstitial tissue, and then the lymphatics, and then eventually go back into the blood. But the whole point is that you, with a positive net filtration pressure, more fluid is leaving. Remember, the drug will move with that fluid. So the natural tendency is for the drug to distribute out of the plasma into other tissues, while it's also being eliminated by different tissues, right? So some of it will go into the muscle, some will go into the, if it's lipophilic, it'll go into the fat, some of it will go into just your other connective tissue. So that can change. So the net filtration pressure can change. So remember, basically the factors that can change that will be things like the hydrostatic pressure. If you had more hydrostatic pressure in your tissue, or for example, if you had low pressure in your blood. But actually I'm answering the questions a little bit that I have on the next slide, so why don't we wait until we get into those. Okay, so I'm gonna ask you kind of an open-ended question on the next slide about what are all the factors that you could think of that would affect, again, this is not just albumin, now we're talking about the other forces that would affect fluid movement into and out of a capillary, and then thereby affecting the drug. The drug that's already dissolved in that fluid will move, with it. So how would that affect distribution? So the question is, what factors would make a drug move out of a tissue and back into a capillary? So why would the drug move backwards? So the underlying assumption here is that if the drug starts off in the plasma and there's nothing in the tissues at first, then and then at some point, then the drug will start distributing into the tissue. Actually, immediately, some of the drug will start distributing into the tissue, and then the question is, then when would a drug move out of the tissue and back into the capillaries, into the plasma? And I want you to pause it now. Okay, and I'm going to answer, if you haven't paused it, go ahead, but I'm going to answer the question with a few of my own thoughts, and you may have some of your own thoughts on top of this. If a tissue accumulates a drug, but the drug is also eliminated from the plasma, eventually the concentration gradient will favor drug movement back into the plasma. So even if the net filtration pressure of the fluid is positive and fluid is still leaving the capillary, if the concentration gradient is forcing the drug to move back in, it might go against the fluid. So that means if the drug concentration becomes lower in the plasma than it is in the tissue, you will draw some drug out of the tissue and back into the plasma, fighting against the fluid movement, right? That can happen, and the drug can go backwards against the fluid movement because of the concentration gradient. And the only way that would happen is if the drug is getting eliminated from the plasma by some other route, like the kidney or the liver, and then that'll deplete it and it'll draw it from another tissue that we're talking about. If an organ's epithelial cells can force the drug against its concentration gradient, the drug may be pushed back into the interstitial fluid and then the blood. Okay, so that means active transport, for example. The easy one is the kidney, primarily the proximal tubule of the kidney. Remember, the proximal tubule can basically take things in the urine, or we'll call that the ultrafiltrate. Right after the drug gets filtered or the blood gets filtered, it'll be in that lumen of the proximal tubule, and that can get reabsorbed. Okay, in some cases, even if the blood concentration is kind of high compared to the nephron or the lumen concentration, sometimes the drug will still get reabsorbed, or nutrient like glucose, remember from physiology, and that requires transporters to go against the concentration gradient. So a tissue can, like the kidney, can force the drug back into the blood instead of getting rid of it, even if the plasma concentration is a little high. So again, the first one was concentration gradient. The second answer was transporters, which will require energy to fight that uphill battle. And then if a patient had blood loss, right, and that's a rare occasion, but a patient has blood loss, the capillary filtration pressure could actually be abnormal. So remember, normally it's positive, but the net filtration pressure might be negative because one of the major forces in that equation is the hydrostatic pressure. If the hydrostatic pressure in the capillaries is lower than the hydrostatic pressure in the interstitial tissue, we'll have fluid recall, or draw fluid back into the blood, and the drug will go with that, right? Because that's part of the driving force for the drug movement, is just the bulk fluid that it's dissolved in, right? So those are the three main ones I could think of, and you might have some other ones on your own, other than changes in albumin. Okay, so if you do have other ones, please let me know, because it's I think it's kind of a fun thing to talk about, kind of one of those stimulating conversations. So on this slide, I wanted to highlight two different factors or different scenarios for different types of drugs and different types of tissues. So some drug distribution is perfusion limited, and by perfusion it means blood flow limited. So the blood flow to the tissue will determine the distribution into the tissue. The kidney would be one good example. The glomerular capillaries, because they're so leaky and so easy to get any free drug, it's easy to get it through. The main kind of factor that's determining filtration is just blood flow. So the faster the blood flow, the more the filtration. And that's because the drug moves very easily. If the drug is there, it'll move easily through the glomerulus. However, some drug distribution is permeability limited. Okay, that means the blood, you can't necessarily enhance distribution just by changing blood flow. So the brain is a really good example. So even if the blood is flowing faster and faster, the distribution or the diffusion through the tight junctions in the blood-brain barrier is so slow that changing that flow of blood in the speed at which that drug is entering that capillary doesn't necessarily help very much in distribution of that drug into the brain. So if you can enhance permeability of the membrane, that would be more profound or have a stronger effect than enhancing blood flow. Okay, it doesn't mean the blood flow doesn't matter. It means that the strongest factor affecting distribution into the brain for many things is going to be just the permeability of the blood-brain barrier. So there's not much you can do to change that, honestly, other than unfortunately if you had an infection, you had meningitis, that actually will weaken the blood-brain barrier, or if you can block a transporter there that pumps drugs out like peak lipoprotein. So again, that's special cases where that can happen. But in general, the things like the brain are permeability limited. Things like the any tissue with very leaky capillaries would be perfusion limited. So before we talked about elimination half-life, and we're going to have a lot more discussion on elimination half-life in the future. I don't have much on this here. This is distribution half-life, and believe it or not, we can characterize distribution with half-lives, and that means if distribution happens in a first-order manner, that for example, if a specific percent of drug is distributed per unit time, then we can basically find a constant for that, a rate constant. The distribution rate constant would be K sub D, and please don't get confused with the dissociation constant for drug binding that we talked about in pharmacology. That would be the KD for affinity. This is totally different. We're talking about a rate constant for drug diffusion into a tissue. The way that is calculated is Q, which is blood flow, which would be something like milliliters per minute, milliliters per hour. So that would be the units for blood flow, and then divided by the volume of the organ. So blood flow divided by the volume of the organ times the concentration of drug in the plasma. So that equation would give you the rate constant for drug diffusion into a tissue. And you can actually calculate a half-life for drug diffusion into a tissue, meaning, which is kind of weird because we're talking about drug appearing, not disappearing, but appearing into the tissue compartment, right? So the half-life would be the time at which 50% of distribution has occurred in that tissue. Okay, so it's not something I plan on asking a lot of questions on because I don't have that in a lot of the calculations. But again, the T1/2 for distribution is the minutes required for 50% of the drug to distribute into the tissue. One of the things I want to emphasize is half-life is never appropriate for a zero-order process. That means if a constant mass per unit time is distributed to that tissue, there's no such thing as a half-life. It's actually undefined, or it's impossible to determine, because half-life by definition has to go through a like a first order or a process by which not a certain mass of drug, like rather than saying like 10 milligrams is distributed every hour, it has to be a percent, 10%, 5%, or something like that, and then it would be having a half-life. Okay, we're going to get into that a lot more as we proceed through the whole course, the difference between a zero order and a first order process. And again, at the bottom, for something that I've never defined before, you'll see the key at the bottom, and I might show the key a few more times, but certainly the first time I use it, you'll see that at the bottom. So this slide and the next slide are meant to show you, first the incorrect and then the correct way of looking at a half-life for distribution. Half-life, it's always, a percent. So if we had a half-life of 30 minutes, okay, what that means is that in 30 minutes we should have 50% of drug distribution. And this is going to be an incorrect example. So let's say in the first 30 minutes we see this. Okay, 12 drug molecules out of the total, and the total will be 24 here, but 12 or 50% enters the tissue in 30 minutes. Right? So that looks correct so far. We're going by half-lives, and that means in the next 30 minutes we should have another 50%. Well, remember, the total amount declined, right? We have a lower total amount over here now. So that is declined. So we shouldn't see 12 again, we should see 50%. So if we saw 12 again, that would be wrong, right? That is a zero order process, because the same mass went, whatever the mass of that drug is, 12 of them went the first time, 12 molecules went the second time, in in the same amount of time. So that means that is a zero order process because it's the same mass. So that cannot have a half-life. It's impossible to define that. So I guess one question is it possible to ever have a scenario where a constant mass is entering per minute rather than a constant percent? And the only way that would happen is if it was a saturable process. So if a drug entered a tissue only on a transporter, and we saturated that, we'd have to saturate that transporter so it can't handle any more drug, then we have zero order movement. And that's really, really rare, right? So that's why I'm calling this, first of all, it's rare, but second of all, this example is incorrect because you can't have a half-life for a zero order process. Secondly, so correct example. What would it look like if we actually did have an actual first order process with a 30-minute half-life? So we'd have, again, just like the beginning, 12 or 50% going in, but then because this is a lower amount, right, now we only have 12 remaining, we should have 50% of that, and that would be 6 in the next, again, it's the same time, 30 minutes. Half of 6 is 3. That's going by half-lives, right? That's a real first order process because it's 50% every 30 minutes. Now eventually, right, we'll get to the point where there's only one molecule left and then it'll be gone, right? So you might be tempted to think that if it's always 50%, well, the drug will never be totally gone. Well, once there's one drug molecule, then that'll be the last one to go, and that's it, right? So you're not cutting the drug in half, obviously. So that's real half-lives, and that's what you need to understand, that it's always a percent per unit time. So in this case, distribution rate slows down as less drug is available. That's very important to understand. The K constant that we talked about, the distribution constant, does not change. But if you use, basically you would use that constant, and we use that in the introductory lecture, those constants. If you take that constant and multiply it by the concentration of drug here, right, you'll get a lower number than if you took that constant and multiplied it by the concentration of drug in the beginning, right? So that gives you the mass moving per unit time, right? So the constant doesn't change, but the mass moving per unit time will change. So that means as the drug gets lower out here, in the next 30 minutes, we'll have a lower amount of drug getting into the tissue. So it declines, right? It slows down as we lose drug, as we deplete that drug from the first tissue that we're talking about on the left here, if that's plasma, etc. Okay, so we're back on this equation. This is, again, the constant for the distribution into the tissue, and it equals the blood flow divided by the volume of the organ or tissue that we're talking about times the R. The only thing that might be a little new to you or potentially not something you've thought about before is this R. You probably never read about it, but the R factor is the concentration of drug in plasma divided by the concentration of drug in tissue, and the key is that that's at equilibrium. That means when everything settles out, if you just imagine if you had no elimination, right? If there were no elimination, when everything is finished distributing, how much would be in the tissue and how much would be in the plasma? And the point is that if the drug prefers the tissue, right? If the drug prefers the tissue, then that should mean the drug moves to that tissue faster from the beginning. That should theoretically give you a higher constant or K value for distribution. So what would make the R lower, again, would be if the drug preferred the tissue, where that's on the denominator. So a lower R, right, because R is on the denominator of this whole equation, the lower R here, right, would give you a higher KD because that's on the denominator, right? That would give you a higher KD. That would give you a faster, and again, this is not the dissociation constant for drug receptor binding. This is for distribution. So that's a rate constant, and the higher that rate constant, the faster the distribution of the tissue. So hopefully that makes sense. So I'd like to, every equation that we have, I'd like you to think about all the factors and make sure it makes sense to you. So if we increase blood flow, or Q, to the tissue, yeah, we should get an increase in diffusion of that drug into the tissue. If we increase the, let's say we increase the volume of that tissue, or V, right, that should decrease distribution, the rate of distribution of the tissue, because it's a larger volume. And if we basically, if we decrease R, that would raise the KD. So the whole point overall is that these three factors, you need to understand these three factors that are affecting KD. At least as importantly as that is understanding what would be the types of properties that would affect R. So what properties of a drug and tissue might give a low R and therefore a high accumulation in the tissue? Okay, so those are two factors, right? The drug and the tissue. So let's talk about the drug. If the drug had, you know, a certain log P, and I don't know how much you remember about log P or what you learned, but that's the partition coefficient, the octanol water partition coefficient. So they take the drug in a lab, they put it in a mixture, or two phases here. One will be octanol on top and water on the bottom, and they shake it up or mix it, figure out where the drug distributes, and if most of it distributes into the octanol, then it's lipophilic. If most of it distributes into the water, then it's hydrophilic. The log P is just a marker of that, so or a measurement of that. So if a log P is positive, right? If a log P is positive, that means the drug is somewhat lipophilic. If it's negative, it's very hydrophilic. If it's 0, it's kind of somewhere in between. So the higher the log P, the higher the lipophilicity. So if, for example, if we were talking about adipose or fat tissue, what would raise the KD, or the rate of distribution into the fat tissue? Of course, if the drug were lipophilic or had a high log P, right? If it had a high log P, that would make this part of the R equation, right? That would make this one higher. So the concentration of drug in the tissue would be higher at equilibrium because the tissue is fatty, right? And the drug is a high log P, and the drug is lipophilic, so that would raise or lower the R, right? Because the ratio is drug and plasma to drug and tissue at equilibrium. So if the R is lower because of a high log P, then the KD will be higher, and that means the distribution is faster. It's a really long way of saying a fatty drug likes a fatty tissue. A watery or hydrophilic drug that likes water will like non-lipophilic tissues, like maybe muscle tissue, right? So non-fatty tissues. So it's that simple. So this slide is really on uptake by organs, and I wanted to highlight the difference from organ to organ. So why some organs are considered fast distribution and some of them are slow. So if you look at this graph here, you'll notice number 1 and 2 would be the adrenal gland in the kidney. And notice that if you administer, whatever drug we're talking about here, but this is going to be the majority of drugs, you administer the drug, and again, it has to have some renal distribution. Otherwise, you wouldn't see this on the graph. But we're saying drugs that generally distribute freely into the kidney, well, they'll do that rapidly. So that means almost instantaneously, if you injected IV, like injected the drug, you would see that get into the kidney and equilibrate with the kidney almost instantaneously. So the kidney is considered generally part of the first compartment, so it's almost distributed simultaneously with the plasma. And then if we look further, skin, of course, is going to take time. If it's an oral dosage form, it has to get into the blood and then get into the skin capillaries and then diffuse into the skin, the dermis and the epidermis. So that's much slower. The muscle is a little slower than that. And then the fat, for anything hydrophilic, the fat is, first of all, low distribution, and second of all, a very slow rate. Okay, and this is why that, if you give a drug now, and for some reason, if your target was in adipose, you cannot expect an effect right now, right? You can't expect the pharmacological effect right now. Maybe, again, several hours later, so like 5 hours later or something like that, depending, right? So, and even if it's lipophilic, it's going to take, it's going to take some time. It's still going to take longer than the distribution in the plasma, which is almost instantaneous. Okay, so the whole point is that every organ will generally receive drug at a different time, and if any organs do receive drug at the same rate, they would be kind of all bunched into one compartment pharmacokinetically. That'd be considered one single distribution phase. Okay, and I have a note on the bottom. The drug in the kidney tissue may be inside the renal epithelial cells rather than the tubular lumen. So the whole point is that even though the kidney is an excretory organ, it does have cells that can accumulate drug. Those renal epithelial cells can be a distribution site, even if ultimately those drug molecules don't get eliminated. So that is possible. Sometimes a drug can have such a low R, meaning it's such a high affinity for that tissue, it may reside in there for days, weeks, or months. There's at least one drug that in some patients has, I think it was like a 260-day half-life, and that was amiodarone. So, and that's somewhat lipophilic. So there are rare cases of drugs that can be distributed and stuck in a tissue for months or more or years. It's rare, but it can happen. And that would, mean that it had a much higher affinity for that tissue than for the plasma. So that would be a low R value. So again, the higher the R value, it would prefer the plasma more. The lower the R value, it would prefer the tissue more. Now, that's not the whole picture, right? Because we're going to talk about the next set of lectures will be on metabolism. Okay, we're going to be talking about that. So if a drug prefers a certain tissue and has a low R value and goes in that tissue very rapidly, it still might get destroyed if that's an elimination or excretory tissue, right? It could still potentially get modified and eliminated that way. So just because it's highly distributed doesn't guarantee that the elimination won't happen at a significant rate. But again, drugs that distribute into things like fat in the brain and things, they generally do take longer to get out of the body, right? So that makes sense. Some drugs distribute slowly to their therapeutic target even. Like I said, like if the target were adipose, even the heart, if the heart is a therapeutic target, some drugs take time to, believe it or not, to get in deep into the heart tissue, even though the heart is constantly perfused with blood. Its prior knowledge is important to understand if you're seeing lack of effectiveness or delayed effectiveness. And that experience is critical. So that means if you give this cardiac drug digoxin, which is used to slow the heart rate or to treat cardiac arrhythmias, if you give that right now and you don't see any effects on the heart, right? If you didn't know better, you might think, well, I better give a little more, and then I better give a little more. It's not working. If you didn't know better, that could result in toxicity, because they know, any pharmacist, an emergency medicine practitioner working in that area would know that digoxin takes some time to work because it takes some time to distribute into the heart tissue. So now I want to get into more detail on just the term VD, or volume of distribution. The VD is a value unique to each drug, of course. It's actually an apparent volume, as it is calculated only from the amount of drug absorbed in the concentration of drug in the plasma. So what I mean by that is the only thing you need to know to get that value, or to calculate it, is how much drug did you give, and you need to know, how much you gave and how much it was absorbed. If it's IV, right? If it's IV, then 100% is absorbed, right, immediately. So, how much did you give divided by the maximum plasma concentration, and that's all you're doing. So it's important to understand that that's the only thing you're doing to do that calculation. And the reason why that's important is because that is not telling you anything about where the drug is. It's just telling you that if I gave this much drug, this is the final concentration. This is the concentration I'm seeing in the plasma at the earliest time point, which would be the maximum concentration for an IV drug. But in some cases, that Cmax is very low. So you give a lot of drug or a certain amount of drug, and then you say, well, why is the plasma concentration so low? And if you do the VD calculation, you might get a number that's astronomically high. And we're going to talk about why that's the case and why that's not a real volume, it's just an apparent volume. So before I do that, I just want to mention that the VD is useful for calculating plasma clearance, which we'll get into in a later lecture. And it's actually a lot more useful for that than for understanding where the drug is in the body. It never tells you where the drug is in the body just by measuring that. So on this slide, I did my best to try to just in a simple way show why the volume of distribution is apparent and not real. So imagine two scenarios. So, and we're going to just do the volume of distribution calculation, just the standard calculation we just talked about. Just keep it simple. Imagine, so this drug, these four black circles here are the drug, and these are the tissues. Now imagine if, and this is just hypothetical, you're never going to get every tissue that has the same fluid volume, but imagine every tissue is 6 liters, right? 6, 6, 6, 6. And then, watch this. So the drug's going to distribute, and I'm saying if this really happened, if we really had the same amount of drug in the blood, tissue 1, tissue 2, tissue 3, and the same volume of tissue fluid, then the concentration would be the same in every tissue. So the volume of distribution here would be 24 liters. So we have 4 times 6 is 24 liters, right? If we actually calculate the drug concentration and use the VD calculation, we get 24 liters. What is the actual volume that the drug is isolated to? Where could we actually find the molecules? Well, it's also 24 liters. However, right, because we're only measuring drug in the plasma or the blood, we don't really know if it's getting into the or what tissues it's getting into. We just know it's going somewhere. We don't know exactly where unless we measure that. So what if we repeated that, like with a different drug, and it did this? What if all the drug went into one tissue? Guess what? This blood amount is the same. The blood amount is, for both of them, they're the same. So that would still make you think or lead you to believe that it's distributing to 24 liters. That's the VD apparent, 24 liters. However, if we actually investigated, we'd see, wait a second, all the drug is just in this one tissue in the plasma, and that's 6 liters. So the real volume that the drug is found in is only 12 liters. So the whole point is that the VD doesn't tell you where the drug is. It just tells you that if the drug happened to be uniformly distributed, what would the volume be that it was uniformly distributed into, right? So that's the key point. So it's just telling you that how much the drug is leaving the plasma, and what volume would that correspond to if it were a real volume. And it's just understand it's not a real volume, right? It's an apparent volume of distribution. Okay, so we actually have a calculation here. Simple scenario. We have a 160-pound patient that is given 3 grams of penicillin by IV bolus. Because it is IV bolus, it's rapid, and we don't really need to consider absorption. So just assume, in this case, we'll assume all the drug got into the plasma pretty much at the same time. So the peak that we found, or the Cmax, was 12 milligrams per deciliter. The first question, though, is what is the volume of distribution in liters? So please pause it, go through all these on your own. That would be ideal if you can do them like right from the beginning on your own. So pause it now and try that. If that tends to be difficult, or turns out difficult, I'll do it a step at a time here as well. And you can, if you can't get through the first step, then you can pause it after that one, after we get through that. But try to do that now on your own. So here's the warning here. I'm going to continue and give the answers right now. So the first question is volume distribution liters. So first of all, notice our C max is in milligrams per deciliter. So we don't need to mess with the mass yet, but we need to know liters. Okay, we have to use it, and that's the rule of thumb for all these calculations is your units cannot be conflicting. You're right. If we want to calculate liters, we should definitely get our any volume units we have into that unit. So how do we convert milligrams per deciliter into milligrams per liter? And first of all, you need to know that there are 10 deciliters in a liter. So all you're going to do in this case is, right, you're going to multiply it by 10, right, because there's 10 of those in every liter. So multiply by 10, you're going to get 120 milligrams per deciliter, or milligrams per liter, sorry. So that's just the starting point. So how do we actually get to our volume of distribution? Now notice that our dose was in grams, but our C max is in milligrams. So we also have to do a conversion there. And I decided you don't have to do it this way. I decided rather than converting to 12 milligrams into grams, I converted to 3 grams into milligrams. It should work either way, but you have to have the same mass unit. So here it is. 3 grams, of course, is 3,000 milligrams, right? There's 1,000 milligrams in a gram. We still have 120 milligrams per liter, and the calculation is the dose divided by the C max. That gives us an answer of 25 liters. What would the concentration be if the drug were distributed just in plasma? So all I'm saying is, right, if we just had the drug going into plasma, nowhere else, we already know the dose. I'm giving you the volume of the plasma. So you would take the dose divided by the volume of plasma. What would the concentration be if it didn't distribute anywhere other than plasma? So it's a simple, just a division there. The answer is 3,000 milligrams divided by 3 liters equals 1,000 milligrams per liter, or 100 milligrams per deciliter. Okay, so I want you to think about that, because if the only compartment that this was dissolving in or distributing in was plasma, the answer would be 100 milligrams per deciliter. But we're seeing, and let's look at the units. We have to be looking at the correct units. We had 12 milligrams per deciliter instead of 100 milligrams per deciliter. You should immediately realize that a lot of that drug has left the plasma. Even at the C max, even at the very beginning, a very large amount of that drug has left the plasma, and that means it's gone somewhere else. So that means a very high volume of distribution. Okay, so again, 25 liters of volume distribution is much larger than the plasma volume, so that makes perfect sense. Now, something that's done clinically sometimes is calculating the volume of distribution per body weight, per kilogram or pound of body weight. So in this case, I wanted to know what is the volume of distribution per kilogram of patient weight. So we already got the volume distribution, right? That was 25 liters. How do we normalize that or calculate that relative to the patient's weight? And that's because if your weight is, if you have someone who's double the weight, they might have, they should have a higher volume, body volume, and fluid volume. Now it all depends. Is it going to be double? It all depends on where the drug is distributing. But the whole point is that your weight affects your volume of distribution. So if you divide it by, well, first of all, you got to get the 160 into kilograms. Remember, there's 2.2 pounds per kilogram. So you take the 160, divide it by 2.2, and then you get your kilograms, and then you'd have to just divide your volume of distribution by the kilograms, and that ends up being 0.34 liters per kilogram. We're not going to do anything with that number now, but I want you to realize you'll probably be doing something like that later on when we get into the clinical realm later in the semester. So I already alluded to these questions, but I didn't. I wouldn't say I completely answered them. So we still have a chance to kind of have our own kind of independent thinking on this. So if a drug were highly lipophilic, how would VD look in an obese patient versus a lean patient if both had the same lean body mass? So let's think about that. You have a patient that's obese, so we're assuming they have extra adipose. We have a patient that's lean. But both of those patients, if you removed all of their fat, and that's the lean body mass, right? If you removed all of their fat, what if they were the same weight? And the question is then, what I hope you're thinking about is, well, how does that obesity affect volume of distribution? How does that obesity affect fluid volume? And the answer, well, the answer is actually, it depends. Okay, it depends particularly on the drug distribution. Okay, but in this case, specifically, we're saying that the drug is highly lipophilic. If you're obese, the drug is highly lipophilic, you will get a lot of distribution into that fat tissue, right? So it'll make your volume of distribution look a lot larger, right? A lot larger if you're obese. Now, the next question is, what if the drug were hydrophilic? How would the above scenario look? If the drug were hydrophilic and you had two patients with the same lean body mass, but one of them is obese, how do you think the volume of distribution would look compared, from one patient to the other one? So think about that and pause it, or pause it and think about it. Okay, and now I'm going to answer that. So, and this is very practical. It's used quite often. You might have already seen this if you worked in a pharmacy or in an inpatient setting where drugs are dosed sometimes based on lean body mass and sometimes based on total body mass. And drugs that are hydrophilic, of course, they diffuse very poorly or distribute very poorly into the adipose. So the change in the volume of distribution will not be that large, right? So someone's VD, if they're obese, if they're using a hydrophilic drug, it may not be that much higher than a patient that's much thinner in terms of body fat percent. So it doesn't mean it won't change at all, but it'll be a very minimal change, because the only difference is, yeah, your adipose tissue does have blood supply, not very much, and that adds to a little bit of volume in the intravascular volume, but for the most part, the drug won't be really distributing that much more than normal and won't be diluted that much. So again, that's why you see hydrophilic drugs usually dosed on lean body mass, very lipophilic drugs, especially if the blood concentration is critical, like if it's a narrow therapeutic window drug, then yeah, you might dose it based on total body mass. If it's, if we're talking about a very lipophilic drug, then obesity would affect that. So it's, again, very practical stuff here. Okay, obese person, higher VD, both patients for a hydrophilic drug, both patients who have a similar VD. So this is my attempt at kind of having a humorous example of why volume of distribution is not real. Why is it apparent? And we already talked about that, but I want to give you an example, a few examples of drugs here that have astronomically high volumes of distribution. So we're just kind of lucky. The reference that I had, the textbook, used chloroquine, and we're lucky because chloroquine is a hot topic because of the COVID-19 and hydroxychloroquine. But chloroquine has a volume of distribution of 13,000 liters. No human has a body volume, a fluid volume in their body of 13,000 liters. So why would the number be so high? How is that possible? And the point is that we're only measuring the drug concentration in the plasma. So if most of the drug is gone from the plasma and goes into fat tissue, for example, it'll look like the drug is diluted in a swimming pool, right? Because there'll be none left in the plasma where we're actually measuring it. So that's why I have this this example down here from a popular movie that I hope maybe, well, it doesn't matter, but if you can figure it out, you might find that kind of funny. But I'm saying that, yeah, like if we had a giant, maybe we can achieve that realistic, or that volume of distribution, that would be real. But in a real patient, right, that's not a real volume. So it's really important to understand that. So the actual body water, if you look on this kind of chart here, the body water would be there. So anything higher than that means it's concentrated in some kind of tissue, because it's not a realistic distribution, right? So that's really interesting, important to understand. And yeah, the log P of chloroquine is 4.6. The higher, the more lipophilic. That means almost 40,000 to 1 is the ratio of lipid to water. So almost all of it's going to be diffusing into the lipid, like adipose and all that. So it's really kind of cool. So on this slide, I have a question that we've actually already alluded to and I briefly discussed a few times. So hopefully you can kind of think of this, but how do you think volume of distribution is affected by plasma protein binding of a drug? So think of a scenario where there's high plasma protein binding, low plasma protein binding, and now that you understand how to calculate volume distribution, how would it be affected and why? So go ahead and pause it. Think about that, please. So high protein binding usually results in a low VD because bound drug cannot diffuse easily into the tissues. So we talked about that. Low capillary permeability. This will only be evident if the analytical method used to basically to measure the drug in the blood can quantify both bound and free drug. So what I'm getting at there is that when a lab when a lab reports a drug concentration, some labs may be reporting the total drug concentration, some labs may be reporting only the free drug concentration. So the total would be the bound and the free, and if they're just reporting free, then you need to know that, and they should tell you that very clearly on any kind of lab report, which one are we looking at, and do they show both. And the reason why that's critical is because, again, only the free portion can distribute, only the free portion can have a pharmacological action. So again, if you double the free, you have a dramatic increase in the pharmacological effect. Whereas if you can only affect the plasma protein binding, if you didn't affect the free, right? And that was a confusing example, but basically, if you're not changing the free concentration, you're not really changing the pharmacological effect, and that's the point. So I want to briefly discuss how volume of distribution and the elimination half-life are related. Remember, the elimination half-life is only referring to the time it takes for drug to leave the plasma. Okay, in this case, I'm specifically saying the amount of time it takes for half the drug to basically leave the body and be excreted. So if a drug has a high volume of distribution, right, that means it's getting a lot moving throughout the body, right? Higher distribution means less chance for the drug to reach excretory organs. So the point there is that if something has a really high VD, it won't have a high enough plasma concentration to get eliminated quickly by the kidney or the liver. So usually drugs that have a high VD have a slower elimination rate from the, if you're actually measuring the amount leaving the body completely. So even though a high volume distribution results in something called a high clearance, and that just means it's out of the plasma. It's getting cleared from the plasma quickly because it's going into another tissue, but it's not getting cleared from the body quickly, right? And to calculate clearance, we haven't really talked much about that. There's a whole lecture on that later, but this is just a brief introduction to it. To calculate clearance, it's actually the elimination rate constant. Here it says K, but I also use KEL, sub EL. So K times VD is the clearance. So the clearance is, from the plasma, is basically made up of the elimination rate and the volume of distribution. So whether a drug is going into the tissues or it's getting out of the body, in both cases it's leaving the plasma, and that would raise the clearance if either one of those values are higher. But again, usually when VD is high, that will drop the elimination rate, or K, right? So those are interrelated. So the half-life will be much longer if you're talking about the total body half-life, right? We have to be very clear on that. So are we talking about plasma or the total body? Right now I'm talking about the drug actually leaving the body. If you could somehow quantify the entire drug in the whole body, the rate of it of leaving the body would be generally slower if the drug is diffusing and distributing to more diverse tissues and at a higher amount. So this, in this hypothetical example, the drug leaves the plasma quickly in the early phase, okay, which will be right here, and then later on it leaves slowly. In this example, so distribution will be pretty fast. Okay, so you inject it, and then it distributes really fast, and then you have basically an elimination phase. And the elimination phase has a much lesser slope, so that means, you know, the drug very rapidly distributed, and then whatever was left in the plasma slowly got eliminated, and then we drew more and more from the distribution tissues back into the plasma, and then those got eliminated. So what's happening is, in the plasma, we're regaining some of the drug that we lost into the tissues. We're regaining that from those tissues while simultaneously getting some out through the kidney and liver. So the plasma has an input and an output at the same time. So what would that actually look like? I'm trying to, in this example, I'm trying to show, you know, what might be happening in each phase. Kind of like a really simple example to hopefully illustrate the point. But imagine we injected a drug into the plasma, and that'll be, again, those are coded by the numbers there. So the first phase 1 there is what's happening, again, right here, phase 1, phase 1. So we're injecting into the plasma, and this is what we see. All the drug is there, you know, approximately around here. We filled up the plasma. Phase 2 is distribution, right? And there's so many distribution tissues, sometimes it'll drop quickly. Now, and I have to clarify, distribution and elimination, they're going to happen at the same time, right? The second one molecule of drug enters the plasma, like one molecule is in the plasma, the elimination process will start, but so will the distribution process. So what this phase 2 here is showing is really a combination of elimination and distribution. But for simplicity on the animation, I'm just showing, let's just assume we're just getting distribution right now. Right, and that was pretty rapid. But so why does this, at the end, it's pretty slow? And of course it depends on the excretion rate. So how much of the drug is getting into the urine, how much is getting into the bile. So it all depends on that, but also, again, we're going to recover this drug from the muscle, the lymphatics, the adipose. So that also contributes to the plasma concentration, and it's going to temper that or minimize the rate at which the plasma concentration will drop. Okay, so what I'm showing is, as this one left, it was replaced by the one for the lymphatics, etc. Right? The adipose one replaced that other one that was in the plasma. So I'm just trying to show you that the plasma doesn't just have separate time points where it's like, okay, here's distribution, here's elimination, and they're all separate. No, they're happening at the same time, and again, we're going to slow down that last phase because of that. So again, the more a drug distributes, generally, the slower the elimination rate, because it's constantly feeding back into the plasma every time we get rid of some. So this concludes the distribution lecture. Thank you for listening. I do not have follow-up questions here, but all the questions throughout the lecture, what I want you to do is kind of go through those again, but also for any calculations, what I'd like you to do is try different scenarios. So, you know, different doses, different body weight, and things like that. Pick a different Cmax, and that's, I mean, really when it comes to the testing, it's going to be the same calculations, but just potentially a lot of different numbers, you know, so different Cmax. And I might, again, I might expect you to do some unit conversions. The volume on the graph might be different from, your desired, again, volume of distribution. If it's liters, if the graph has milliliters or deciliters, you have to make note of that. Other than that, that's it. So again, thank you, and will be next. We'll be covering metabolism.